Hello, everybody. We are live at 11:06 a.m. on October 3rd, 2025. I cannot believe it's already October. We are here on Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. I'm Lisa Salberg, and I'll be your host today. And with me as my co host is Dr. Harry Lever. Harry, welcome to Tales from the Heart.
Yeah. Okay.
Always a man of few words.
Right.
Okay. So I want to do some of my updates for October 2025, kind of let you know where we've been, what we've been doing. When last we spoke, I was in a hotel room in DC podcasting with Nat Martinez, who was in Brazil. Today it's just New Jersey and Ohio, and here we are. I'm finally back home. I've been on the road for about 7 weeks with some breaks at home that were maybe 3 to 4 days long in between some of them. But we've been out there quite a bit doing some amazing work over the past couple of weeks. Um, the last conference weekend, we had a split crew. Actually, we had a triple split. We had a group working here in Jersey, in Newark, at the for the All Hearts Collaborative Project, which I'll update in a minute. Then we had a group out in Minneapolis at the Heart Failure Society of America conference. And then Julie and I were in Denver at the American Academy of Pediatrics. We're going to kind of highlight some things in the next session here with Dr. Lever about the American Academy of Pediatrics view on vaccinations. And then we're going to talk about adults with heart disease and vaccination recommendations from ACC. So that'll be coming up in a little bit. Um, what we did at the American Academy of Pediatrics was we were distributing our new activity book for kids, which, if you're watching, you can see the All Hearts Collaborative Activity Book and crayons. They went over really well. And then we asked the question that is behind me. This is our pop up from that event for those who are watching live or watching the video. And the question we posed them with was, do you think it is important to know a child's family heart health history? And that's the no side. There's nothing on it. And each heart represented somebody else who stopped by our booth. So they covered the entire yes side with hearts, and they even signed some and colored some. So it was very clear that pediatricians believe that it is a very important conversation to have. And we are looking forward to making it legislatively required in all states that every well child examination includes a family heart health history screening. Okay, so that's my updates from there. At the close of today's session, I will be discussing some of our legislative initiatives, but I'm going to hold that to the end and where we are with some of them. So stay tuned for that. Harry, there's some new stuff out in the literature now. So in this first segment, we're trying to kind of cover what's new and hot. So what are you seeing out there, and what's your perspective on some of the newer data?
Well, there's two new drugs, mevacampten and avacampten, and they look like they're certainly the mevacampten's been released, and the other drug is still being studied. But it looks like they're going to be very good for patients with hypertrophic cardiomyopathy. The question is there a big difference in exercise function with, and they've talked about some of the blood studies that are done, and it looks like they're positive, but we're not 100% sure about whether the exercise testing is positive yet, but it certainly looks very favorable. And I think that these are going to be drugs that we're going to be using. And
So we're
yep,
talking a little bit about the MAPLE study results,
right.
which was that head-to-head beta blocker versus calcium channel blocker, or I'm sorry, beta blocker. I'm so used to saying versus calcium channel blocker, and it's wrong, versus myosin inhibitors, and who did better on an exercise study. And the patients who were on a myosin inhibitor did much better,
Right.
and the beta blockers did actually worse than baseline. So that was intriguing, which then made everybody think, oh, let's just throw away the beta blockers, but not yet. We're not ready to throw away beta blockers. They
No,
still have a role in HCM. And it may just be that cautionary tale to the patient and to the clinician that if the obstruction isn't resolved, you don't just keep adding beta blocker. That doesn't solve the problem. We're not getting to the mechanism. So, beta blockers still have a massive role in HCM. We will talk about the importance of knowing what kind of beta blocker you're getting in our next segment. But did you ever think there'd be this much interest in creating new therapies for HCM, Harry?
No, I thought no. Well, I mean, the problem was there weren't a lot of studies that were done early on, and
Well, I think
that's been, if you go look at some of the older drugs, were not a lot of studies.
there were not, and we didn't get there.
No.
And now we're here.
Yeah.
Now we're here. So I am going to pivot to part two of our. So we did our late breaking. Oh, other late breaking. October 18th is the HCMA annual meeting. If you're not signed up, you can do so now. We have a lot of scholarships available. So if the price tag's a little hefty, don't worry about it. Give us a call, apply for a scholarship. You'll probably get one. We've got about 40 seats open with a scholarship right now. So if you have not signed up, please do so now. Call the office if you need some assistance, 973-983-7429. So join us for that. Join us for our gala. It's going to be a lovely evening. If you want to come on out and support the cause, we have some interesting auction items that might even include an experience that you might not get an opportunity to participate in otherwise. Okay, so Harry, there has been a great deal of information floating around the ether about the role of vaccinations, specifically for flu, COVID, and RSV, we'll cover as well. And I know you have always been a supporter of vaccines in the population in general. And I thought today we would cover this really important piece that the American College of Cardiology issued for adults with heart disease. And I'm going to do a screen share here. You want to talk to us a little bit about what you think is important for people to know about
Well,
considering vaccines this fall?
I think that people with heart disease really need to make sure they don't get any of these diseases, particularly COVID. COVID is a big one because if you happen to have coronary artery disease, the COVID can really have adverse effects on the coronary arteries. So you really want to be very careful not to get the disease, and that's why you need to keep up with your COVID shots. It works out in reality that it comes out to once every 6 months, believe it or not, and I've kept up with it as well as my wife has. And the other thing is, it's extremely important, believe it or not, you still need to wear a mask. If you fly on an airplane, if you're around a lot of people, you really should be wearing a good mask and try not to get this disease. So between the vaccinations and the masks, there's a good chance you might not get the problem, and it's really important. And
I would agree. I think when you look at this document, this is just a web page. You guys can go here. The link is above. Julia, could you drop the link to the ACC data? It's the second one that I put up there earlier. So this is telling us that adult vaccination rates are low. Most adults are not aware that they even need vaccines. Recommendations for the healthcare providers are the strongest predictors whether somebody's going to get a vaccine. And there are many missed opportunities out there. So ACC is working to help people understand the role. And if you want to do your own research and you want to look at the data, then you can go on, click onto this piece here, consensus, clinical guidance and ACC expert consensus for adult immunizations as part of cardiovascular care. I would encourage you to read it. If you have any underlying cardiac conditions, it is wise to get both your flu and your COVID vaccine.
Actually, I was surprised. This appeared a few days ago in my mail at home. I couldn't believe what I saw. I even called them and said I really thought they had done a very good job at putting this out. But it,
Well, our props to their current president, Chris Kramer, good friend. So,
right,
Chris, organization's doing a great job. Thank you. So, I think they did do a good job on this, and I think
right.
it is very fact based, and I think it's very scientific. And I encourage everybody to take a look at this if you are an adult with HCM or any other form of heart disease, and pass it along to your friends and to your communities online if you're talking to other patients as well. This is the guidance from ACC. Now, let's pivot for a minute, and I'm going to take this screen down and bring up another one. And that is probably one of the more complicated issues we've dealt with in a long time due to, oops, why is it doing that? Sorry, didn't want that one. I have to add a different one. Sorry. Um, there we go. We looked at, sorry, there we go, share screen, technical issues. At the American Academy of Pediatrics, there was a great deal of talk on two topics. I'm sure you can imagine what they were. So it was vaccination and acetaminophen. So that's the second topic. We'll touch that one ever so briefly. But the AAP has issued their recommendation for child and adolescent immunization. They do not specifically speak of children with heart disease. So I would take some inference from the adult experience and then look at the child experience and make your decisions as a family. But flu, COVID, RSV, and kids with cardiac conditions or living in homes with others with cardiac condition or coming in contact with others with cardiac conditions. This is the APP guidance. Julie, are you dropping those links in there? Because I'm not seeing any. I don't know what's going on. Um, so that's weird. I'm not showing them. So please take the recommendations of the American Academy of Pediatrics and the American College of Cardiology and all of their partnered organizations, which you can find on their website, who also support these two guidance documents. So there's your data, there's your links, there's the science. Please do your research and make good decisions for your family. Harry, do you want to talk for 2 seconds on acetaminophen?
I I
No.
think it's a very good drug. It needs to be used particularly if people have fever. You can you if you let the fever go too high, 103, 104, you could have a seizure, and you want to make sure that that doesn't happen. So I mean, Tylenol has been used for years, and there's no concern about it, at least in my mind. And
I
I
will bring everybody back to that document that a lot of people have been talking about, and that's the Harvard study. Just because you say Harvard study doesn't mean that's the conclusion of the Harvard study. And I would encourage everybody to look very closely at the conclusion to that Harvard study, which basically states we don't know really why these people were sick, why they took the Tylenol, and what the underlying cause was. And there may be more to why they took the Tylenol than the Tylenol. So until we have causation, please don't freak out. Look at the conclusion of that study. It's not what the headlines read. And I'll leave it at that. Okay.
It's
Harry.
also important that you use name brand, like with a lot of things. You should be careful about that, not buy the generic, because over the counter drugs, believe this or not, don't even have to be tested by the FDA.
And that becomes a big problem
Right.
because we don't really know what's going on with the quality of a lot of our over the counter
That's right.
drugs, our supplements, and even our prescription drugs, which is a battle that you and I have been on together for almost 20 years. Probably, yeah, about 20 years.
And actually, the other drug that you have to be very concerned about is ibuprofen. There's been a
Hmm.
lot of recurrences of pericarditis now, and studies have not really been done to look at what's going on. but a lot of the ibuprofen is coming from China, and you've got to be very careful what brands you're using. I had a very interesting case a number of years ago of a woman who had um, an aortic valve replacement, got post-pericardiotomy syndrome, which is inflammation of the heart after heart surgery. And she got it, was admitted to the hospital, felt better after she was treated with ibuprofen and colchicine, discharged, went to the drugstore and bought another brand, got into trouble. I saw her about the second or third time she came in for the first time. And what we did was we put her on name brand over the counter drug that was 200 milligrams for ibuprofen. But what I did was I had her take 3 tablets 3 times a day. So she got the correct dose, and within a month she was cured, had no more problem. It turns out that the brand that she had been given at the drugstore was called Indian Grains, and the Indian Grains came from India. And once we stopped that and got her on name brand, even over the counter, but it was name brand, then she got better. So you got to be careful.
We got to be careful with what we're putting in because we
Right.
don't know where it came from.
Right.
So the generic drug quality issue, as I just seem to refer to it as, has been going on for quite some time, and it also impacts our over-the-counters. We know our friend David Light has done a great deal of work investigating what these drugs actually are, and he was the person to uncover the problem with Zantac, that there were carcinogens in Zantac, and it got pulled from the market a couple of years ago. So super important to think about, where our drugs are coming from and what is actually in the bottles. So there was a Senate hearing earlier or late last month on the topic. Did you get a chance to watch it, Harry?
Yes, I did.
Give me
And
some of your thoughts.
well, I mean, I was encouraged to see that the senators were concerned. That was the big deal. And as a matter of fact, I had spoken to one of the senator from Florida, uh, blocking on his name right now. At any rate, one of his assistants, and we had a discussion for about an hour about all the problems with generic drugs, and I think I woke him up a bit. I was very glad that we had the discussion and told him that we really have to be concerned about, where the drugs are coming from, and the fact that you got to test the drugs, and that's what David Light is doing, along with the Defense Department. They're in the process of testing 40 drugs, but it's going to be up to 100. And because they feel that you got to be very careful about soldiers and what medicine they're getting, and like if you're treating somebody's blood pressure and you don't give them the right stuff, the blood pressure may not be under control. I mean, I've seen that for years.
And we've seen the problems with certain generic drugs that are used in HCM, specifically metoprolol.
Right.
So knowing that the quality of the drug could vary based on the manufacturer and the dosing, because it's only required to be between 80 and 125% of the original. So if you're overdosed on one, like it's 125, and you get a new one and now it's down to 90% or 100%, you're getting less drug. And when you're used to 80%, then you get 120, then you're really overdosed. So there's a lot of different things that could be going on. And these are sensitive drugs in a sensitive heart, so they need to be evaluated very carefully.
Right.
And we hope that there will be some movement on the Department of Defense Authorization Act that will include some more surveillance that will be made transparent through the website where pharmacies can purchase their medication. The goal is that they will see what the DoD has done in their evaluation and their rating, making that transparent so that we can all benefit from knowing which drug is a better quality. That is not available to the public at this point, We would hope that they would be even more transparent so patients could gain access to that on an easy basis, so they would know which generic drugs that they could trust. And there is an effort to bring more manufacturing back to the United States, which would improve our ability to inspect laboratories when the drugs don't do what they're supposed to do. Right now, the process to evaluate um, those facilities is limited because you need to make an appointment, set it up. They get 3, 4 months lead time. And there was a great video or a webinar like 2 weeks ago by MedShadow where they had Peter Baker on and they had, I forget who else they had on that one to talk about
Gray.
the inspection policies. Do you want to talk a little bit about that webinar?
Well, yeah, I mean, it was basically the same sorts of things that we've been talking about, and um, again, where are the drugs coming from? And it's interesting. I had occasion to speak to Peter Baker a few years ago. He's an FDA inspector. He was written up in the book Bottle of Lies, as was I. And Catherine Eban put me in touch with him. She's the author of the book. And turns out there was a plant in India a few years ago that was making metoprolol succinate called Walcart. And he had been in that plant. And I had written a letter to the FDA telling them that I was very concerned about that brand of metoprolol succinate. And as a matter of fact, I had been written up in the New York Times about it, that stuff. And he said to me that I was absolutely right. The FDA had written me back and said, oh, they didn't find a problem. They didn't find a problem. So he told me that I was absolutely right because when he was in that plant, it was one of the worst places he had ever seen. And I was really surprised to hear that. And then I had, we had just talked on the phone, but it was really kind of neat to see this guy at the hearing when
That is funny. So that was the first time you actually saw him in person,
yeah,
huh?
the first time I'd actually seen him was at the hearing.
Oh, that's so funny.
Yeah.
Um,
So,
my
but
apologies to our people out on Facebook. Something was wrong with the feed, and I've just gotten us live onto Facebook. So, hi, Facebook folks. We're here now. The starting part of this podcast can be found on the YouTube channel or over on LinkedIn. So when we put it together as a full podcast, you'll hear the whole thing together. But sorry, you guys missed a piece of it here, and I'm actually looking for it on the page, and I'm not seeing it, so I can share it to the group. So Julie, you want to just keep an eye on that, and then get it over to the group so they find it over there too. Technical issues. I haven't sat at my podcast station for a couple weeks, so I'm getting reused to everything. Okay, so Harry, what would your hopes be for new policy or improvement in the evaluation of generic drugs as they come into this country? What does
well,
perfect look like to you?
well, I think that I've worked with David Light and a few other people, and we're coming up with a testing criteria where we're going to grade the drugs from green to yellow to red. And if you find enough bad stuff, we're going to call it red, and you don't dare use that stuff. So what we're hoping is eventually there'll be some notification put on the drug that this is red or it's green. If it's green, no problem. And it's interesting that some of the stuff they have tested has been okay. It's not like everything is bad. It's just a matter of testing it. The other thing is so that we know what's good and what's bad. The other problem is with the change in climate, you got to be very careful how how the drugs come to you. If they're in a truck for a long time and the truck's hot, it could ruin the drugs. The other thing is that there has to be periodic testing. I mean, food is tested all the time, and the idea of not testing drugs, that's really bad. I had a patient one time who worked for one of the food companies, and they would test the drugs all the time to make sure that There was no bad things in them. As a matter of fact, I found out that one of the food companies that makes ketchup, and it was one of the more common ones, is Heinz. They have a device that tested the ketchup for metal fragments. So all their batches of that food ketchup was tested for metal fragments when they would before they'd sell it. So, but things like that, of course, metal fragments probably aren't in drugs, but whatever. But the idea of not testing batches of drugs is a real problem, and it really needs to be done.
It would be our hope that everybody would be able to be confident in their medications.
Right.
Not only our patients who need them to live and have improved quality of life, but also our clinical trialists. And I keep going back to a meeting that I was in about, I guess, 4 years ago, December. It's literally called the Clinical Trialists Meeting. It's cardiovascular clinical trialists, actually. It's always the first week of December in DC. And there was a group of people sitting in a room really pondering why the clinical trial results were not proving out in real practice. And they had all these ideas about non-compliance on the patient's part. They're saying they're taking their meds, but are they really taking their meds? And I believe that if somebody's going to pick up a prescription every month, they're taking the meds. They're not just going there for the fun of it. They're not, maybe we forget once in a while. I've even forgotten my transplant meds like on 3 different occasions over 8 years. But generally, we're compliant patients. We want to do the thing. We want to have the benefit of the therapeutic. We want to make sure we're taken care of. So I listened to them blame the patient a little bit, which happens a lot. And then I said, "Are you guys giving them name brand or generic?" And they went, "Oh, all the insurance companies only pay for generic, so we're giving them generic."
Yep.
And I schooled a team, and these are smart people. They're really great people. I said, "Do you know that the Generic Drug Quality Act, has these limits, 80 to 125? And do you know that the dissolution rate is really tricky and it's not working in some?" And I'm explaining why it's not working. And I'm like, "So if you're using these as background therapies for other clinical trials, we have a problem that your background therapy may not be what you think it is. And if you're actually thinking that the patient is going to respond exactly like the clinical trial, you're not comparing apples to apples. You've got maybe 2 different kinds of apples and maybe 2 different kinds of oranges, but they're oranges. So are you comparing real comparators, or are they different?" And I had like jaws on the ground all around me, like, we did not know. We did not know. I I got a round of applause from the entire room when I broke it down and I explained what the problems were, because nobody in that space had ever actually thought about it that way, because we don't talk about it. And even the FDA's own website is a little misleading, and it's always been misleading. This is not an administration issue. This is just, it's always said generic drugs are equal, and they're not. They're not even by regulation required to be equal. So, how do we gain transparency? Any ideas, Harry?
No, I mean, I think that there has to be requirements that how often the drug, actually, every batch of drugs should be tested. And that there should be no question about it. And if you
And I
can't,
believe the cost should go on to the manufacturer. They'll pass it on to the patient. That's fine. But why would you buy something that is not the right quality,
right,
and you're going to ingest it and you're going to have all the downstream consequences of
right,
not having what you think you have? Mm.
yeah,
Okay. So we've had a Senate hearing. We have some proposed legislative language to be added into the Defense Authorization Act. We're in a budget shutdown right now, so nothing is moving. We sincerely hope that we get to resolution, and I will put a pause here. You will notice that my nails are yet again another color of purple, which is indicative of where I find myself in today's world. We must talk to everybody about the hard problems. And as of right now, we are losing subsidies on the ACA plans. And that is going to mean massive rate hikes to families throughout the country who are getting care through these plans. And that is going to make them unaffordable in every jurisdiction in this country, whether they're red, blue, purple, green, I don't care. They're humans and they need access to health care. So we need to come up with a solution for that. And we need to come up with a solution to Medicaid funding. The children who are treated in the South specifically, I will talk about one Florida Children's Hospital. 70% of the kids there get their coverage through Medicaid. And a lot of the families that we work with are also on Medicaid because they have existing heart conditions and it makes it impossible for them to hold a job. So I'm sorry, we have heart problems, but we need a safety net. I have been traveling the world quite a bit this year. I've been in a number of different countries with a number of different health systems. And where we differ from every other system is there's a public system and a private system in pretty much every other developed country. And we need a stronger public system, and we need to keep advancing our private systems. And that means public pay and private pay. So private pay is your regular health insurance companies, but they are a for-profit entity. They're out there to make money and they own their own PBMs. And we need to put some guardrails on this process to make sure that we aren't wasting money. And I don't see the role for PBMs. They're not really saving us any money. These list prices on drugs are ridiculously high, but that's not the price you pay because there's all these games. And we need transparency in that pricing. We need transparency in the relationships between PBMs, the payers, which most of the payer systems own their own PBMs now. They're buying their own hospital systems, and they're becoming this linear healthcare system that's not serving the patient very well in all cases. So, Harry, healthcare is changing, and we really need to have some tough conversations. And the people who are in need of these services need to go talk to their elected officials and just explain life. What does it mean to be reliant upon a device that costs money to get in and out of your body and to monitor? What does it cost to have to be on pills for the rest of your life to manage something as important as your heart? You need to get those stories to the elected officials to explain how you can be a productive member of society with the aid of medication and access to it and therapies. So we are living in really challenging times, and we're going to have to think creatively on how to solve problems.
There's
And I don't know where
also
they're going to
a
go.
big problem getting appointments for people.
Yes,
We suddenly have developed a shortage of doctors,
yes,
and we need to some degree, COVID wiped out a lot of physicians in terms of being extraordinarily fatigued and busy and suddenly not being able to keep up. And that has to change too. And so that's another problem. And you've got to it's got to be very carefully looked at. And and some of the other problems has been research money has been taken out of different sorts of groups.
Without research, we're not going to get to where we need to go. And I'm not sure how much the general population understands about how early science is conducted and then when it spins off to private interests. And what tends to happen, from my perspective, as being in patient advocacy for 30 years and working with these different systems, our federal systems through the National Institute of Health, CDC, and some other agencies, there's a number of them that do research, including the Department of Defense does medical research, and a lot of people don't understand that. There are multiple ways through the federal government to fund research, and those research findings become public, and that public information can then be used as a basis to develop a new therapy. And then it spins off into a company. And then that company has to go out and raise more money to bring this thing to fruition and go through the clinical trials process, which is not an inexpensive process. So the company then does the discovery. And it's reasonable that that company benefit from their contribution and that they make a profit off of that. That's okay. They built the thing we needed, we can pay for it. But if we're cutting out the NIH funding, the base science isn't going to get done because there's no money to be made in it. And it's a social program. It is to improve the health and wellness of the community, the whole. Do I think that there needs to be some cost share and then profit share potential? Yeah, maybe. Maybe there's a way to do that differently. Let's talk about it. Let's not just shut it down. Let's talk about it. What can we do to fund this that makes it fair? And what do we charge people for access to these medications? That's fair. How do we work on focusing on the overall wellness of the person over time so that we stay functional members of society, so that we can pay our taxes, so that we can contribute to the greater good? We want to do that. Most people want to be healthy. And if you have a disease that gets in the way of that, we need a therapy that can make us better. And we're really good at the science these days. And we have better therapies than ever. We just need to make sure that we're maintaining access to those, which is why I'm encouraging everybody to talk to their elected officials about what their real life experience is. Harry, what do you say? What's going on from your perspective?
Well, I've tried to get in touch. I must be honest with you. I've tried to get in touch with certain politicians. I was successful with that, the one that from that hearing, but a lot of our local ones, it's very difficult to get in touch to try to get messages to these people. You know, we write letters, we try to call them on the phone, and it's not as easy as you always think to let people know what's going on. But I think we have to keep pushing hard, and I think that we have to let them know that people are suffering, and if
Yeah.
that's big problem, and it got to be can't be afraid to talk to people.
No, we can't be afraid to talk. Conversations can be hard. We have to understand that we're not going to see eye to eye on everything, but instead of just shutting down the conversation and either yesing somebody to death when that you really don't believe them, or just saying you're an idiot, I don't believe you. That's not the way we communicate. That's not the way you make progress.
No,
We need to sit and have hard conversations. We need to have meaningful conversations about what we can all do to make this better.
right.
So, for some of our listeners, don't know this. Um, some don't know it. Some might know it. Some may know me from this part of my life. I wasn't always in the nonprofit space. I came from a business environment where I was in human resource management and health plan administration. I managed the health plan, and it was a self insured health plan. I wrote it, I managed it. We beat the market by 18%, sorry, 17% out of the 18 years that I did this type of program. And we got those results because we allowed physicians to make decisions that were serving the patient the best, and we didn't get in the way of that. This concept of prior authorizations is an administrative juggernaut that slows care,
Right.
and you can catch the fraud, waste, and abuse by doing retrospective evaluations on what these people have already done. You can find the data right there. You don't have to stop everybody because one bad actor did too many procedures or didn't pick the right patients. Look at guideline directed care, hold that as the guidance. Let's gold card programs who have good behavior and let them go through without all of this prior authorization nonsense. It slows everything, and it's not efficient for the insurance company either. They're spending so much time and energy. It's nonsense. So we need to have conversations on how we can maximize the systems that exist. What do you think, Harry?
No, I think it's very important. You have to. make sure that people are doing the right thing and not getting in the way of taking care of people. I mean, that's, and sometimes to have non-medical people making medical decisions is a big problem. And
It is.
that has to stop. And, you have to, people, you gotta understand who knows what. And I'm not sure always the insurance companies know everything there is to know.
And they're some of them are leaning into AI, and they're allowing AI to make decisions, which I don't want to vilify AI. I think there are some really good, useful scenarios for artificial intelligence to augment the work of humans and to improve upon it. I'm there, but there are certain things that need a human touch and a human eye, and we need to make sure
Well, as a
that
matter of
human.
fact, some of the medical decisions being made in the state of Ohio is going to be with AI, and we're concerned about that.
I'm very concerned about that, because all you need to do is have one variable entered incorrectly
Right.
into your AI algorithm, and you're not going to get the right answer. And to go
Right.
back and figure out the why nots is going to be a nightmare. It's going
Right.
to be a nightmare.
That's right. That's
So
right. So,
we need to make sure that
right.
we're evaluating this new technology in the best way possible and
Right.
using it for the greater good, not for the purpose of it's as if people who don't understand healthcare delivery just assume everybody's lying to get services, that it's all nonsense and people are just complaining to complain. There are sick people. There are disease processes. We are a biologic entity. We are going to break. You are all going to break in some way at some point, bigs and littles. Like, we're going to have big breaks and little breaks. We're going to get viruses. We're going to get bacterias. We're going to have disease states. We uh, get cancers. We're going to get heart disease. And we need to be able to manage our bodies with therapeutics that are available to us. Everybody will become a patient. And even if you don't think you're going to become a patient, one day you're going to be walking out of a studio and you're going to trip on a carpet and break your leg in two places. Hello, that happened to me. So you never know. You never know. So we all need good coverage. Okay, have I beaten that horse sufficiently, Harry?
Yeah, I think so.
Oh my goodness. Okay. So legislatively, yes, Mark. Mark said, here, let's put that one up on the screen. That's cute. One of your old patients here, fighting for years to help me for quite a while now before you retired. So we have Mark, who is here and who wants to say hi. So there you go. And to Sally. Hi, Sally. Say hi to Sally, Harry.
Hi.
She's not, I don't know that she's watching right now, but we were with Sally last Sunday night in Colorado, and she's an old patient of yours, and she thinks the world of you and wanted to send her regards.
Right.
So there we go.
Right.
Now, Julie has dropped a link for you all a little earlier to our You Join campaign. If you don't know how to speak to your elected official, we have a sample letter that you can send to them, and you can put whatever additional content you want in that. And you can even do a little video and you can tell them what you think. So share your video, share your words, share your story, and you can use this as often as you'd like and let them know what you're thinking. So we've dropped that, and we'll make sure everybody has a copy of that in the chat. Okay, so legislative initiatives that we're working on include the Children's Cardiac Safety Act. And this weekend, while we were at the AAP, we had the opportunity to meet with a lot of different individuals about the initiative, the legislation, and what pediatricians feel about this. Something has become very clear to me over the past couple of months, and it's a little bit of a pivot from where we've been before, but I think it's time to make this pivot. We've spent an awful lot of time talking to the cardiology community about HCM and who we are and what we need. And we're still only at about 15% of those who can be diagnosed getting diagnosed. Ladies and gentlemen, I think the rest of the people are not getting to cardiology. I think they are stuck in their GP, pediatrician, general practice doc's office with symptoms that they're unable to articulate because of the inconsistent nature of symptoms with HCM, the fact that our murmurs can come and go, and some of us are non-obstructed and have no murmur at all. So I think the battle lies with the general practitioners getting a better understanding of genetic heart muscle disorders and making those referrals. So the way we can help facilitate change is through the Children's Cardiac Safety Act, and that will enable every well child examination to start talking about family heart health history. And I will make this prediction today on October 3rd, 2025. The more we get pediatricians to ask about family heart health history, the more they'll get used to the fact that they're seeing more of it than they thought. And they'll come up with their own strategies on how to refer each type of heart disease and to whom. So we have the opportunity to change practice. Typically, that takes 7 years to make practice changes. But there are people out there that are at risk today. And we know that they are at risk today. And we know with better questions and better engagement with community physicians, we're going to be able to identify more of them. So if you agree that we have to get out of cardiology to get the referrals to cardiology, and you want to help us in our endeavors, we need all the help we can get. And we need all the partnerships we can get. So we're talking to some pretty big people about some pretty big partnerships that we're not ready to announce yet, but might be coming very soon. So get ready for a pivot. Get ready for some projects that are more community based that you're going to hear about from us. And if you really believe in the cause and you want to help us out, make a donation, become a volunteer, get involved. We need a bigger boat. We need a bigger message, and we need to get out to the masses. And we're ready. We have the infrastructure to support them. And every patient who's diagnosed, we will hold their hand through the journey and make sure that they are aligned with the highest level of care that we can provide for them. Currently, we have 57 centers of excellence in the United States. But I'm not going to lie, changes are coming. Some programs are going to be added and some may be sunset because healthcare systems are changing. We are doing our very, very best to ensure that there is consistency in care throughout the country, but hospital systems are changing. And there are some new players to the table that we need to make sure understand our patient population and our need for care. We're thinking out of the box. We're thinking more virtually. We're thinking, what can we do there? Just at the point we're thinking of what more can we do, a lot of the virtual health systems were shut down by the government shutdown and are no longer available right now. So that's not your institution. That's a federal system that failed. So if you had a virtual appointment that was canceled, this is the price of a shutdown. There's different prices and you'll see it in different ways. So that's what's going on out there. Harry, if you had a magic wand, what would you do to fix it?
Well, I think it's a matter of getting out and telling people, and and you know, and not being afraid to tell them that that's what I think you got to do, and we can't let people get hurt, and you got to make sure that hospitals stay in business. The idea now to hear that some hospitals are closing.
It's mostly the smaller hospitals that are closing,
Right.
and that is to our rural clients. They may find themselves 2 to 3 hours away from the closest hospital.
Right.
And if you're having a cardiac emergency, your chances of survival have diminished greatly by the loss of that institution.
That's right.
And that is not the direction I think we want to be moving in this country, in any country. We want to be improving care and ensuring access. And I know that there are people out there that are scared right now. And I have a couple of pieces of advice for those who are worried about their access to care. I don't have answers that are going to make it all better. I wish that I did. But I'm going to encourage you to make sure that you have called your physician and requested an appointment before the end of the year. They're probably not going to be able to get you in, but it'll be documented that you tried to get in. I would encourage you to fill all of your prescriptions as close to December 31st as possible, but please do not wait until December 31st because I think we're going to deal with shortages and outages. So through the month of December, make sure that you've got a 90-day supply of drugs that could get us through a window of time that is going to be precarious for some. If you are on programs that have patient assistance programs, contact them and ask them this very important question. If I lose my health insurance, is there a program available for me? Many programs are available to subsidize other programs. You may not be able to get access to certain medications if you do not have insurance, and going on to Medicaid may no longer be an option. So I know many companies are working on safety nets for these patients, but some of them haven't been created yet, and some of them may not be able to be done. It's a scary time for people on coverage that is expensive. Do your very best to maintain your coverage. And if you cannot, we will continue to look for pathways to get to what you need. It may not be perfect. We can't answer every problem, but we're going to try to make sure that we know where the charity care programs are for you. Most major hospital systems have charity care, but if everybody's going to be tapping into it, it's going to go bankrupt pretty quickly. So the safety net for the safety net may fail. We need a sustainable long-term system. I have seen no proposal to date that talks about modification of healthcare access through systems in any way that seems functional. I caution you all on Medicaid Advantage programs. Please do not sign up if you can at all avoid it. They do not cover the same medications. They do not cover the same procedures. They are problematic for many. So stick with a regular Medicare and supplement program if you can at all do so. There is a very big attempt to push you into a Medicare Advantage program. Remember, an Advantage program works much like an HMO, that doctor gets a certain amount of money to take care of you, and that's all they get. So if you're a chronic illness patient, we take a lot more resources than the well patient. So they can't really give us all the attention because they got to take care of the smaller problems as well as the chronic problems. So it's not an optimal program for somebody with a condition like hypertrophic cardiomyopathy, especially in 2025 when some of our medications are more expensive than they used to be. So just shout out there that this is the world we're living in. We didn't create it, but we're navigating it along with you. And it's going to get more challenging before it gets easier, I suspect. Harry, you've been around a while. You've seen healthcare changes. Have you ever seen anything like this?
No,
Neither have I.
no. And I think we have to let people know that it's got to stop. I mean, it's gotta, you don't take health care away from people. That's what has to be.
I can't believe that we're having this conversation. I'm so saddened by it. I'm so disheartened that we can't come to the agreement that the health of our fellow Americans matters so little to some and so much to others. We need a sustainable system going forward. We need a sustainable system going forward. It's not going to be perfect, and I think it's going to be very different than what some people are currently experiencing. But we need to get there, and we need to get there together. Together. I am on my I think 8th month of purple nails as my symbol that red and blue must come together and make purple, and we need to work together to solve these problems. And I encourage us all to have good conversation, Okay. I'm going to wrap up with A little reflective story time. I told this story to Julie in the car ride home from the airport the other day, and I wanted to bring this person back to the forefront and tell a story that does have a sad ending, but there was a moment of optimism in there, and I think the world could use this at this point in time. So once upon a time, there was a lovely client of the HCMA. His name was Dave. Dave actually stepped in and did some navigation calls for us while I was getting my heart transplant. I'd known Dave a long time. He was originally a minister. He left that calling and he was too sick to do the work and kind of lost a little bit of faith, which makes sense because he was on a bad course at a young age and needed a heart transplant and wasn't going to get one where he lived. So he moved and he went to a place where he had a better chance of getting a heart. He had to do some pretty amazing things to get his heart, including getting first a total artificial heart, one of the first people to actually do that. And he was getting frustrated with the total artificial. It made a lot of noise. It was very restricting. He just wanted to get to transplant. And he called me one day in April and said, I'm at the end of my rope. I don't know what else to do. I can't live like this. I need this heart. And he was broken and he was sad and he had given up. And I could hear it in his voice that he wanted to be there for his boys and his wife, but he couldn't be there anymore. And he felt very lost. And I did too. I pulled all the magic tricks out. I got him to the right doctors. We navigated him as close as we can to that solution, but it still eluded us. And that was in office number 3, as I call it. And I would drive home from office number 3 and I would pass the Catholic high school and the convent. And it was a teaching convent, and nuns would come in from all over the world to learn how to be teachers. And there was this nun that I kept seeing walking around that time of year. And her name was, I learned later, was Sister Fetus. And I stopped on my way home from work the day that I talked to Dave. And I said, I know I look like a crazy lady pulling over and talking to you here, but I need you to pray for this guy because I got nothing left. Could you put a prayer in for him? So she wrote his name down and she said, we will pray every day. I said, thank you. And I went home, didn't think much of it. I would see her walking. I would now wave to her when I saw her. She was very sweet. And a couple weeks later, I got invited to a fundraising event at Morristown where they were talking to the big dollar funders and they were bringing in patients who were served by their programs. And we brought down some HCM patients and families to participate. On the way to that meeting, I get a call from Dave's wife saying he's getting a heart right now. It's happening. So, yay, Dave gets his heart. I'm on my way to this fundraiser. And we get there, and the MC announces that they had also been working with the convent and mentions specifically a nun from the country of Burundi. I'd never heard of Burundi before, but I knew that Sister Fetus lived in Burundi. What were the chances of all of the programs and services that the MC would bring up? He'd bring up the nun from Burundi. So now I'm in the room with the woman that I asked to pray for Dave, and Dave is on a table in a hospital in Pennsylvania getting a new heart. So I went over to the gaggle of nuns, and I say that with love and respect because they were all in their different colored habits and gowns because they're all from different sectors of the Catholic Church. So I walk over to the nuns and I say, is Sister Fetus here? And they said, yes. And they pointed me to Sister Fetus. So I walked up to Sister Fetus and I said, do you remember me? I'm the crazy lady in the white car who stopped you and asked you to pray for Dave. And she said, I do remember you. And I said, Dave is getting a heart right now. So let's just talk about this for a quick second. This is a woman from Burundi. And she is learning how to be a high school teacher, but she knows nothing about science or technology. And I'm explaining to her that this man has a total artificial heart and needs a new heart. And these concepts are very foreign to her. So it took a little understanding, like to say he's on the table getting a new heart right now. And then the nuns formed a circle and they all prayed for him. And there was this just lovely moment of connection. And I've been thinking a lot about Dave. Unfortunately, Dave passed away from complications after a second transplant from COVID. So, A, get your COVID vaccines because you're protecting the people around you, like Dave, who had to go through 2 transplants and then died from COVID, which is horrible. And secondly, sometimes we're a lot closer than you think. So, remember that we're all in this human game together and that we can care for other people. We can wish good things for them. We can wish them healing. And maybe, just maybe, those positive energy signals will get around and we'll all be a little bit calmer and a little bit more committed to each other's success. So there's the story of my friend Dave, and shout out to his family. I hope they get a chance to watch this. I'll post it on her page. But stick together, people. It's easier to stick together than to pull apart and be divisive. So that is my message for you all today. A happy story, big heart, big life. Thank you for that one, Julie. Dr. Lever, you've had those patients in your life that made a difference, that make you remember them. And then we see people being divisive and wanting not good for people. Isn't it easier to wish for good?
Sure. Absolutely. Yeah. That's why I went into medicine, to help people. From the age of, I knew at the age of 16, I wanted to be a doctor.
What do you think society as a whole needs to learn about compassion in medicine? You saw a lot. You've been through a lot. You've seen good and you've seen bad.
Right.
What do people need to understand about the compassion that goes into practicing medicine?
Well, I mean, that's what we're there for, is to take care of sick people, I think. And you have to, it's not about, I hate to say it, but it's not about making money. It's about taking care of people. And that's what you have to do. You have to, there's been too much talk nowadays about finances, and there's got to be more about helping sick people. And that's what it's all about. And you have to, that's what you have to be.
I think if people weren't so afraid of healthcare expenses, that we make it more affordable for people. For God's sakes, to have a child in this country is ridiculously expensive today. And tell that to somebody in Canada and they're like, you pay to have babies? It's like, yeah, we do actually. And we pay a lot. I have been in medical debt most of my life because I have a complex health history and I pay the bills. I do what I got to do. And that's what we do. But boy, it'd be a lot easier if I didn't have that financial burden all the time of having to pay to stay alive. Kind of an odd situation when you're working to make money so that you can get health care, so you can stay alive, so that you can work to make money to get health care. And it's just this constant circle that we're stuck in. And I think there's ways out of this if we all work together and think a little bit more smart. Think a little bit more. It's not smart. It's structurally and logically and scientifically, and allow people to have access to the highest level of care that's possible for the disease state that they're facing. Don't put barriers, put bridges.
Right.
Okay. Well, Dr. Lever, it is always lovely to speak with you and have you here on Tales from the Heart. And now I'm off to have another meeting and try to build a better future. October 18th, annual meeting. If you've not signed up already, please do so. If you're worried about the cost, we have a bunch of scholarships available. Call the office and say, I'd like a scholarship. You're probably going to get one. So join us here in Morristown, New Jersey on October 18th. There's the information. There's a gala that night. You can join as well if you are interested. And the next day, we're doing our first 5K. You can walk, you can run. So you can walk a mile, you can run the 5K, or you can come and volunteer. It's our first 5K that we're doing as HCMA. And if we can get the wheels off of this, we can drop them into other cities so you can do them elsewhere and have fun and raise money and raise awareness for HCM and other big hearted disorders. Thank you all for joining us today, and we'll see you next week on Tales from the Heart. Thanks, Harry, for joining.
Okay.